Welcome to Why We Mask, Vaccines and Variants of Virtual COVID Forum. This forum is part of the Why We Mask campaign led by the Christina Lee Brown Environment Institute. Before we begin, we have a few housekeeping notes. This forum is being recorded. Also, to access closed captioning, please click the three ellipsis icon to find the option turn on live captions. And if you have a question at any point during the panel, please enter it through the chat feature for us to include in the Q&A portion near the end. If your question is for a specific panelist, please be sure to specify that in your message. You can join our Why We Mask campaign by sending a selfie where you're wearing a mask and a quote of why you are masked or vaccinated to envirom@louisville.edu. Providing today's welcome will be Matthew Stanley. Matthew is the university's new special assistant to the president for COVID response, and we thank him for providing today's welcome. Matt, you have the floor.
Thank you, Natasha. Good afternoon, everyone, and again, welcome to today's virtual COVID forum. I would like to start by thanking the Environment Institute for their hard work in putting this event together. This is a tremendous opportunity to share and learn from amazing experts in their fields, and I know we all greatly appreciate your efforts in making this happen. To date, the COVID-19 pandemic is responsible for nearly 700,000 deaths here in the US. But the University of Louisville is working hard to combat the spread of the SARS-CoV-2 virus. We have learned so much in the last year and a half of dealing with COVID, not the least of which is how important it is to the mental health and well-being of our students, faculty, and staff to be back here on campus. So much learning and education takes place outside the classroom in social settings. We're only able to do so through the hard work and dedication of our entire campus community to making our campuses as safe as possible. In just 2 months, our student vaccination rate has increased from around 30% to 86%. We were able to accomplish this through providing pop-up vaccination sites and giving opportunities for scholarships and free tuition to incentivize vaccinations. Students and staff alike are adhering to mask and social distancing guidelines and enhanced testing, all of which helps minimize the spread of COVID-19. Further, we support increased educational opportunities as we continue to understand the pandemic. I'm particularly looking forward to today's discussion because this panel brings together multidisciplinary expert researchers and leaders on COVID-19. These include Dr. Aruni Bhatnagar, Director of the Christina Lee Brown Environment Institute, Dr. Sherry Babbage of the Dental School, Dean Paul McKinney from the School of Public Health, and Dr. Lynn Roser from the School of Nursing. You can find their full bios on the event website. Today's discussion will be moderated by SJA President Ugana Okori. Ugana is a senior studying public health and healthcare management. In addition to her role as president, she serves as a COVID-19 contact tracer for the university. Ugana has been part of the Student Activities Board, Society of Porter Scholars, and the President's Council mentoring program. She is passionate about the intersectionalities between public health and social justice with hopes to eliminate inequities within the healthcare system. And with that, I'll turn it over to Ugana.
Thank you, Matt, for the kind welcome and introduction. Today's panelists have a wide variety of expertise and experiences that have led them into the leadership of the COVID-19 crisis. To kick off today's discussion, I'd love to hear from each and every single one of the panelists about your career and what inspired your interest in COVID. Let's start with Dr. Bhatnagar, then Dr. Babbage, Dean McKinney, and then Dr. Roser.
Well, again, first of all, thank you for inviting me to the panel and thank you for doing this. And what you're doing is incredibly important and timely because we need to understand what is happening in our community and how to best respond. As you know, I've been at the University of Louisville since 1998. I came here from University of Texas My research interest has always been in cardiovascular medicine, and that's what I've been doing for a long time. But within that framework, I've been particularly interested in the effects of exposure to air pollution, particularly air pollution, air particulates that people breathe, and how they might contribute to the risk of heart disease. Coupled with that, I've been interested in looking at similar exposures with smoking, cigarette smoking, and now vaping. So when the COVID pandemic broke, we had really had no expertise in understanding infectious diseases, less deal with it. So what we sort of committed to do was to actually jump in the fray, help where we can, try to develop ways of measuring the COVID-19 infections and so on. So because it was a need of the hour, so we got into it, but we had no pre-existing expertise in infectious diseases per se.
Hello. Thank you. Go ahead, Dr. Babbage.
Okay. Good afternoon, everybody. I'm Dr. Sherry Babbage Melisizwe. I am a dentist, and I have been in practice. This is my 40th year being out of dental school. And for 38 of those years, I practiced dentistry in West Louisville. When I came here from Eastern Kentucky as a coal miner's daughter, I grew up in the Parkland neighborhood, and that's where my practice was primarily located. I have a heart for West Louisville, and I have a heart for healthy people in West Louisville. So I've been able to use that love and be instrumental, I think, sometimes in getting the trust of the community. And I guess that's where my desire for the COVID came from, along with the fact that I was on the Board of Health for 13 years. And I always call it health of the public, rather than public health. And for me, it's health of the public for West Louisville and teeth, So I'm glad to be here. Thank you.
Thank you. Dean McKinney?
Yeah, so my interest in infectious disease outbreaks, similar to the one that we're facing now, goes back some period of time. Back in 1976, when I was a medical student, there was a major outbreak in Philadelphia during the summer, during the bicentennial of the U.S., that later became known as Legionnaire's disease, this unusual infectious disease that was linked to air conditioning towers, and that affected some 200 individuals and about 30 deaths within a very short period of time. So that was kind of the beginning, but 76 was an interesting year because there was also the swine flu that reappeared, or in brief form, at least it was threatening to reappear. It did not resurge in major numbers, but there was a campaign to immunize the nation against swine flu, and swine flu just didn't show up. So that was, a kind of reverse situation from what we're facing now. But later on, again, as a student, Lyme disease began to appear and be recognized. As a medical resident, I took care of patients with toxic shock syndrome before the etiology of toxic shock was fully recognized, and decided I needed to, be part of the investigation team to work up diseases like this. So I began work with the CDC in 1981, post-residency, and those were the days of HIV/AIDS, the early days before any etiology of that disease was known. It was felt to be possibly a toxin exposure, heavy metal exposure, anything, was being looked at, and finally determined that there was a retrovirus that was the cause of HIV/AIDS. So that was very exciting times. But I linked those years of experience with CDC into work as a hospital epidemiologist, as a primary care physician, and later when I came here to the University of Louisville and the School of Public Health was being initiated, felt this was a perfect time to take my experience in population health, public health, and apply that to the problems at hand in the city. And right after that time, we had the anthrax exposures in Washington and New York, and we had SARS-1 in 2003, which did not affect our country, fortunately, to any substantial degree, but affected Canada to a huge degree to our north. And then we've had multiple outbreaks since then. We had, the swine flu that occurred in 2009 and 10, pandemic flu. We've had Ebola. We've had concerns about Zika virus, and most recently, of course, COVID. So it's been a long odyssey, from medicine to CDC to epidemiology to public health, and it's a great place to be, and one where I can kind of link all of my knowledge from the medicine world into the public health arena, and hopefully help to prevent disease and further outbreaks to the extent possible.
Thank you, Dr. Roser.
So my name's Dr. Lynn Roser, and I'm with the School of Nursing. And my background, I have over 36 years of nursing experience, mostly in the cardiovascular field. I left academics in 2010 and started branching out to infectious disease, and was a nurse epidemiologist at a hospital in Lexington for several years. And then I worked as the infection prevention nurse for the state at the Kentucky Department for Public Health. And then I came to University of Louisville, where I could combine what I know about the cardiovascular system, heart failure, some other things that I had researched, like negative emotional states, biobehavioral influences, but I was particularly interested in depression, anxiety, and hostility among heart failure patients. And of course, lo and behold, we find that in the COVID population. So I was invited to be a part of the CIRID research group. And from there, we formed a cardiovascular group. And we have had numerous manuscripts on what descriptions of risk factors in COVID patients for cardiovascular events. And the first paper that we published was on the first 700 patients that we had in Louisville through a consortium that the School of Medicine helped form with the Department for Public Health there. And it revealed some surprising things, and there were differences in blacks and whites. So race was a factor in some of the differences, but we are now doing research on 1,000 patients, new patients, from September to December. And already we can see a difference in what risk factors are for adverse events, probably owing to the standardized treatment that began surfacing in September on. And I guess that about sums up what I've done. We are now pursuing studies on vaccine hesitancy and negative emotional states in COVID patients, and COVID patients that have heart failure. So that's the next part of my research.
Thank you all. It's really interesting to hear that many of you were not working in the space of infectious diseases before COVID, and with that felt called to do something to help. We'd love to hear more about how COVID has affected your specific area of work. So going back to Dr. Battinger, last year you launched the Co-Immunity Study. Please share what we're learning about COVID specifically in Louisville and about the innovations your team has made in assessing wastewater.
Yes, so when the pandemic first broke, we had no reagents, tools, kits to measure who was infected and what to do. So with a group of our team together, we put together a project called the Co-Immunity Project. And the first thing we did was called phase one of the project was to test all the healthcare workers. So our colleagues at the Center for Preventive Medicine, Predictive Medicine got together, and they created a kit to measure infections in people infected with COVID. They got approval from the FDA, and we tested over 700-800 of our healthcare workers, because there was no commercially available test to even figure out who had COVID. So after that, we have been using that assay, plus we developed antibody assays to be able to tell who has had the infection. And we launched the second phase of the Co-Immunity Project, which was to do a community-wide evaluation of the rates of infection. And in order to do that, most sort of hospitals or most cities just simply measure whoever comes up to the front door, say, I want to get tested, they test them. Or they just go out and say, people, let's go tested. So but that never gets you the representative population of who's infected. So we launched a program in which you do a random sort of a selection of people from different parts of the city, and then send them letters of invitation to join the study to get tested. And that way we would have something that represents a population of people from different parts of the town and different sort of ethnic and demographic backgrounds, so that we could have a good collection of people that who we can test. So anyway, so that's what we've been learning. Using that, we have been able to trace the course of the infection throughout the last year and through last month. We just finished our studies in the last round in August. At the same time, we also did studies on the wastewater. We were collecting wastewater for different sort of areas around the town, and then we can actually tell what is the level of infection in the wastewater. Plus, we can also identify variants in the wastewater. So we have learned a lot about how the wastewater levels of the virus can predict what's happening in the community, and how we can detect the viruses, in what type of viruses are in the wastewater. For example, when we first started doing the wastewater, most of our viral strains were what we call the alpha strain, or the parent strain. And now in the last few months, that has been completely swept over by Delta. And so 92% of all infections now, or at least the wastewater, whatever we can detect is all Delta. So we could see this change of how one variant knocks out the other variant. We could see from which part of the city this infection starts, what are the pockets of the infection. And now we can see that if there are people in certain pockets of the town that have low levels of vaccination, have high levels of infection, right? So we can see where those populations are, and to give the authorities and people like Paul some information about what is going on with the community, so we can create a much sort of informed and educated response.
Thank you for that insight. Now, Dr. Babbage, congratulations on being named a COVID-19 hero. Please discuss how you kept emergency dental care up and running during COVID, and what you're doing now to encourage vaccinations.
I tell you what, the School of Dentistry, which is, where I retired to be a full-time teacher, but it's been unique because our dental students, let me go through a little timeline, I guess, here with you. Our dental students can't do dentistry remotely. That's a patient hands-on, that's how they learn. They see their patients. Then the school itself treats those patients. So we had people that were coming here as patients that needed their dental treatment. And of course, if you let something in dentistry go a year, like some people have, it turns into something a lot more serious. So we didn't want to do that. We have people needing their dentures, just a lot of things. So when the school closed in, I think it was March, I don't remember exact dates very well, the school closed and the faculty were put on furlough. They were trying to get a plan in place to keep our students and our patients and our faculty and staff as safe as possible. Because we knew our students, some of our students were only a couple of months away from graduation, needing to finish. And on top of that, they had an exam they had to take. So to be able to practice dentistry, you have to do a clinical examination. So we had students that needed to take an exam, no place to take it just yet. So our school was very proactive. I have to give all the praise to our leadership team. Our dean got on it just as fast as he could, and he got us dentists, a few of us back in the building, able to treat those emergencies. So what we didn't want to happen, we didn't want those COVID patients, we didn't want our dental patients to start using the emergency room as a place to seek dental treatment with an emergency room and a hospital full of COVID patients. So that was our stimulus, to be able to get back into the dental school. So we had limited access in a limited place to be able. The other thing that dentistry does, it creates this aerosol. You turn that drill on and you've got dust and particles in the air going all everywhere. So, we needed to be safe. Our first priority was the safety of our patients and our staff that were here. So we were able to get the dental school up and running for emergencies. I volunteered because emergency dentistry is something I like and ready to do. And I knew that a lot of the emergencies would come from our underserved neighborhood. So that was my other stimulus that I had to be able to be here. So I came and volunteered to be one of the people that was here seeing emergencies. Then, I had an opportunity to be back in the community because we have a satellite place where we send our students for training down at Shawnee Christian. So I was able to go to Shawnee Christian and be able to see patients there as well. The other thing that I was able to do was to become a vaccinator. So I was at LUVAC. I trained, they allowed dentists to get a CDC certification to be able to give the vaccinations. And I must tell you, giving a shot in the arm is a lot easier than giving one in the mouth. So, I felt like that went over really well. I haven't done a lot of that because I haven't been needed. Our nursing community has stepped up to the plate and taken on most of that, and the health department. So, but and then the other thing was, early on, as soon as the vaccine became available, I knew that there would be some hesitancy in the African American community. So I used my church, St. Stephen, as a way to, because we were doing our virtual services, and we had sometimes 5,000 to 8,000 people watching those services. So the pastor allowed me to come in with my past Board of Health credentials, to be able to talk to the people and demonstrate that I was going to get the vaccine as soon as I possibly could. And since I don't necessarily like being the patient, I thought if I did it publicly, it would make it a little easier on me and I wouldn't back out. So I felt like, and so I decided to find, and it kind of came to me one day when I woke up. It's that simple, that when you open the vaccine, you give 10 of those, right? So I needed 9 other healthcare professionals. So I located 9 other African-American healthcare professionals to get the vaccine with me. And it kind of blossomed into a media event, which was not what I was expecting. And hopefully we were able to dispel some of the myths that African Americans have and to get more people vaccinated. So that's how the progress went. Now at the dental school, we are over 90% vaccinated here at the dental school. And that's a good thing. I mean, we have hundreds of people coming in and out of this dental school every day. And nobody's closer to aerosol than the dentist. We're up close and personal with you, so in order to do our job. So hopefully we're all going to be safe and keep using our protocols. I don't want the public to relax. We're getting a little relaxed, I think. We're starting to not wear our masks. We're starting to, be out in public. I'm vaccinated 3 times. But I'm still putting my mask on when I go out in public. So at the dental school, I think we've done what we need to do to be able to ensure that people are healthy.
Thank you. Dean McKinney, we've seen you share your expertise displayed on a number of television and radio interviews. Please share about your experience with the National Advisory Committee on Immunization Practices.
Yeah, so that story goes back a few years. Back in 1998, I first joined ACIP as a liaison member for the Association of Teachers of Preventive Medicine, which is now called the Association for Prevention, Teaching, and Research, APTR. So there are several organizations that sit on the ACIP as liaison members, groups like the American College of Physicians, the American Medical Association, American Nursing Association, a whole bunch of them. But those groups meet together with the voting membership of ACIP, which is a core of about 15 individuals, and the federal representatives too, from places like FDA, from the NIH, from HRSA, from the Veterans Affairs Department, et cetera. So we all get together and meet, and of course in the past year and a half, it's all been virtual. So it's different than the way things used to be. But in the beginning, the original schedule for meetings was about every 4 months, about 3 times a year we would meet. In the past year or so, we've had 18 additional meetings that were unscheduled, that were due to pandemic-related issues, development of the vaccines, recommendations for the groups to receive it. And when the Pfizer vaccine was first made available, we had to review that, and then the Moderna vaccine, and then J&J vaccine, and then for all the differing, recommendations of different age groups and so forth. So lots of time spent in discussion, reviewing data, thousands probably of slides of information from the pharmaceutical companies, the manufacturers of the vaccines, from CDC, from FDA, and looking at, we're very interested in looking at side effects, trying to make sure this vaccine makes sense for people. It clearly does make sense. And while there are certain side effects that are recognized, the likelihood of any harm from the vaccine is entirely dwarfed by the likelihood of harm from COVID if you were to get it. That's true really across the board. And there's certain, really especially rare events like anaphylaxis, we're prepared for, we can respond to immediately, people can get treatment. So that's not an issue anymore, although it was, of concern at the beginning. So anyway, back in 1998, at that time, of the original group, no one else but myself from that era is still on the committee. So I've been on for 23 years. I've got the record right now for sitting members, and it's about time for me to rotate off after almost a quarter century. But this has been an incredibly fascinating period to see the inner workings of this decision-making process. We hear not only from the experts, we hear from the public too. We hear all the anxieties, the concerns. We hear some misinformation, some disinformation, things that are blatantly untrue. And that helps us, I think, in formulating plans to how to deal with that, to how to counter information that's incorrect, that you hear from some sides that the vaccine will kill you, that people die after getting the vaccine. Well, people die every day from a whole bunch of reasons, right? And if you look at the people who have died within any given period of time, within a few days to weeks after receiving the vaccine, there's no evidence in these situations that they're dying because of the vaccine. There are other explanations going on, that people who are getting the vaccine have high-risk conditions. Some have heart disease, some have cancer, and so forth. So these people need protection, and some unfortunately will die regardless. But it's not the vaccine that's getting them. It's other things that's doing that. And similarly for the myocarditis issue, that's been raised as a concern for especially young males. The myocarditis that is associated with mRNA vaccines is a mild problem that usually resolves within a period of just a few days. The people who require hospitalization usually are in the hospital for a day or so. And the complications from the virus-associated myocarditis, because COVID itself, the coronavirus, does cause a myocarditis. It's very severe. The likelihood of complications from that are probably 10 or 15 or 20 times higher, substantially higher than any small risk from the vaccine. So it's a process of balancing risk and benefit and how to communicate that information to the public to help reassure them that this vaccine is one of the very safest ever developed, and certainly the most thoroughly studied of any vaccine ever in the history of the country. And I can tell you that the CDC has taken steps in the past to withdraw vaccines that were unsafe. Back in the late 90s, there was a vaccine against something called rotavirus, which is a childhood virus that causes diarrhea. That vaccine was associated with a complication called intussusception, which means the bowel kind of telescopes into itself and causes obstruction of the intestinal tract. Well, that was recognized through early study of side effects. That vaccine was terminated. It was removed from the market If there were a problem with COVID vaccine that were causing some side effect like that, that was causing early complications of a major degree or death, that vaccine would no longer be on the market, because I've seen this happen. CDC and its committees review data very thoroughly, and anything like that, that type of signal would be recognized and acted upon very promptly.
Thank you. And Dr. Roser, as a nurse, you bring a trusted voice of health communication. And we see that you've recently published a paper on COVID and cardiovascular events. What can we learn from your research?
Well, my research has numerous areas. I'm certified, I'm nationally certified in infection prevention, and also a fellow in the Association for Professionals in Infection Prevention and Epidemiology. So I bring kind of a unique thing to our research group. When I was first invited to be on CIRID, there was nobody that really wanted to take over the cardiovascular group, and I felt like, well, I would like to be on that, but I needed some strong physicians that were interested in that. So I invited a person that I'm friends with that I know very well, Dr. Zhiping Wong. And he is a cardiothoracic anesthesiologist with an interest in heart failure. And I thought that fit into this study very well, because what we're finding is there's an increase in heart failure among people who've had COVID, and an exacerbation of heart failure for those that already have heart failure. And some of that is due to the myocarditis that Dr. Mckinney talked about. And I just want to reinforce what he said. You might have a very mild type of myocarditis and after the vaccination, but it is nothing compared to what happens in the hospital when you have COVID disease. And the reason that we hear a lot about men having it is it could be that we just find the difference in men and women, because you have women that a lot of times are underdiagnosed with things, and these are healthy men that are being diagnosed with myocarditis after vaccination. But getting back to the group, so we formed a group that it's really very diverse. We have biostatisticians, we have epidemiologists, we have the one and only nurse, and since then one of my students who has become a nurse is on the group, and he's very wonderful. He's in the DNP program. And then we also have Dr. Pawi, and he is the cardiac surgeon that just implanted the first artificial heart, in a female there. And so we have a lot of experience in cardiac, and I was very interested looking at COVID and heart problems that develop from having COVID. And so our first paper really deals with what are the risk factors that might be predictive of cardiovascular events. And those endpoints are the cardiovascular events with death, obviously. And then we also looked at things like myocarditis, pericarditis. We looked at vascular problems like DVT, pulmonary embolism. We looked at myocardial infarctions, development of arrhythmias and stuff. And what we found is that blacks and whites had very similar risk factors, but there were a few unique things in the black population. Now, one thing that we found that was surprising to us is BMI was not a predictor, even though at the time that we were studying these patients and they were hospitalized from March to June, that's what was in the literature. And we analyzed it every which way we could, thinking we were missing something, but it just didn't come up. And but we did find some biomarkers were the same for both populations, like your C-reactive protein, some of your inflammatory markers, some of your biomarkers were very similar. In whites, they tended to have risk factors that had more comorbid disease as far as hearts were concerned, so cardiovascular comorbidities. In blacks, it was more comorbid disease in pulmonary and diabetes. And, that is not really a surprise to us. And it could be that, there could be some problem with access to health care and early diagnosis for blacks, and sometimes, no follow-up. But that is what we found. And so you know, at that point in time, remember, there was no standardized treatment, so people did poorly, and there wasn't a huge difference in mortality rates for either one. You know, blacks tended to do worse, have worse outcomes than whites, but their mortality was not a significant difference. In the new group that we're looking at, which is 1,000 patients, and they are undergoing treatment, we're starting to see different things pop up. And in that group, BMI was a significant predictor of cardiovascular events. We also are looking at, you know, what the echo changes are and what EKG changes that we see. And the echoes have shown that we have people who have COVID tend to develop more diastolic failure than systolic failure, which really surprised us. And we've also found that people that have COVID tend to have more right ventricular hypertrophy and elevated pressures, which is probably due to the lung pathology. So I think there's a lot to be learned, and seeing, you know, heart failure and myocarditis are two of the complications that have really come out during the past year. So I think as we analyze this data, we'll get more information to guide us in that. Like I said, I did work with negative emotional states in heart failure patients, and I wanted to apply that to COVID patients, as well as do subgroup analysis between blacks and whites, and between people who have heart failure and those who do not. So, you know, we're in the process of trying to get that started. And with the vaccine hesitancy that we are doing and hope to get funding for, we're actually going to not only look at students and faculty, but we're going to look at vulnerable populations, such as blacks. And St. Stephen's Church is one that we have targeted for that. You know, he's a very wonderful pastor that, you know, agreed to work with us. So Dr. Babbage, I was really excited when you said that. And then we're going to work, the School of Nursing staffs the clinic, the racehorse clinic, where a high number of Hispanics, Latinos, Latinx population comes, because they work on the backside of the track. So we're going to look at them. And interesting enough, when we were there, you know, we started asking questions, why aren't you vaccinated? And they said, because work does not require it. So, you know, that kind of surprised me, because I really did not think, I don't know how it will look statistically or anything, but, you know, that kind of surprised the nurses there and me, because, you know, I didn't expect that answer, but I have heard that Churchill Downs is going to start requiring vaccination. So I hope that will change. And then we're going to look, we wanted to look at the LGBTQ plus community, or they now call it sexual and gender minorities, only because they're a population that a lot of times is underserved. And although it's not that they have so much vaccine hesitancy, is do they have access to the vaccine, and what are their feelings about it? Because there's really not much in the literature about that. So I think there's a lot to be gained from our research. Of course, I'm a nurse and I yield a different perspective on it, but the School of Nursing, as you said, has been highly involved in the mobile clinics, in the drive-through clinics, so we were giving vaccines all the time. And so we got a lot of the questions from patients about, you know, what about the vaccine? What are the side effects? You know, will this happen? Will that happen? Which is going to be the next topic of discussion, so I won't go into that. But I do feel like nursing brings a different perspective to this, and because we're with the patient so much. And there's other things I'll talk about as we move on. I don't want to jump the gun, but there we go.
Thank you all. Not only is it inspiring to see how you all have served your field during this time, but it's wonderful that we have your expertise right here at the University of Louisville. Right now, there's been a lot of media attention and coverage about people who are vaccine hesitant, and there's also been a lot of coverage on many myths about the vaccines on the internet and on television. So what would you say to someone who is vaccine hesitant? And further, what myths could you debunk? And in this time, we can start with Dr. Roser going first.
Okay, well, we got a lot of questions in the drive-through clinic in the arena about fertility issues. And that really surprised me until I started looking into it. Well, so one of the first things, now at that time that we were given the vaccines, which started in January, pregnant women were not recommended as a group to get it. There was a study going on, but we usually said you need to talk with your doctor and you need to make a decision. But a lot of times people think that it'll affect their ability to get pregnant. And what the data has shown, and a lot of pregnant women have gotten vaccinations now, so we have data, is that early on when we began the studies, we saw that women who were getting vaccinated got pregnant, even though they were asked not to, and people in the control arm got pregnant, and they got pregnant at about the same rate. So we know that it didn't really affect ability to conceive. And they've done in vitro studies looking at the quality of the eggs and fertilization of the eggs, and they found no difference in that. But there have been some differences. Women have reported, and this is anecdotally, that there's been changes in their periods, the duration, the amount of blood that they lose, different things like that. So there is an NIH study that is now going on to look at that. But I repeat, that is anecdotal information, that is not study data information. It's something that we're going to study, and it may show that there's no change in that either. Women also ask, well, if I get, when people had gotten the vaccine and were coming back for their second one with their doctor's permission, they wanted to breastfeed. And again, we didn't know much about it. The vaccine does go to the breast milk, but it does not have a deleterious effect on the baby. In fact, it's thought that through that the baby may acquire some antibodies that the mother has. It wouldn't be a lasting, protection or anything like that, but that's not unusual in vaccines. As far as miscarriage, we found in that same study with the control arm and the people who had vaccines and then became pregnant, miscarriage was about 14% until they age adjusted it, and it reduced to 12.8%. So, and it occurred at the same rate that people who were not getting the vaccines. So, that was a relief to a lot of people. People ask, will I be able to get pregnant? And of course they would. And I think that we're going to provide some references for you all. Then one of the things that was misinformation has to do with DNA and the fact that this is a messenger RNA vaccination, and it was put on a lot of social media sites. And what happened is these media sites said, well, they're introducing this spike protein, and this spike protein is the same spike protein that women use to grow and develop a placenta. And so from that, people deduced that it would interfere with the pregnancy or introduce DNA to them. And both were untrue. And we have made a lot of gains in looking at social media and what's being said there, but they are two distinct proteins. They have nothing to do with one another. So consequently, it does not affect the pregnancy. And the pregnancy is able, it continues, and the babies are being followed, and we have not seen anything. And like Dr. McKinney said, and any time that we start seeing things from the data, they pull things right away. I mean, the CDC is very good with their vaccine, how they moderate everything, and they are asking pregnant women to become part of studies and to report with vaccine safety. And so we'll be getting a lot more data, but right now we recommend all people age 12 and above get a vaccine, including pregnant women, unless they have something that is different that they need to discuss with their physician. That is the recommendation of the CDC. Now, another thing that I found that a lot of the males ask. And even when I was given flu vaccines, because we had a COVID sign up, I had several people ask about, does it reduce sperm? Will they be able to impregnate a woman later in life? And, I don't know where that one came from, except again, social media and stuff. But what the study showed is that pre and after the vaccine, the quality and number of the sperm was the same, essentially the same. However, if you get a COVID-19 infection, a lot of times sperm count is decreased. So that really is something that you should make very clear to men that, their sperm, if they're worried about reproducing later in life, and that they need to consider that after they get a COVID-19 infection, their sperm count may be reduced. I think that's about all. I put some sites. There's so many myths out there about COVID-19, but my particular area was supposed to be fertility. So I'm trying to stick to that so that I don't rain on anybody else's parade, and you have limited time to deal with things.
Thank you. John Mckinney?
Yeah, so let me just add one thing, if I could, to what was just said about the pregnancy issue, and that is, CDC has really sounded the alarm about the risk to pregnant women of COVID infection. I mean, it's very clear that infection poses major risks to the health and survival of pregnant women, and the vaccine itself is entirely safe. This has been, studied up the wazoo now in so many ways, as was mentioned. But the risk of spontaneous abortion or miscarriage, the risk of stillbirth, the risk of congenital malformations, all these things have been looked at very carefully, and there is no change. There's no increased risk whatsoever. So the risk of the infection is tremendous. The risk of the vaccine is nil. There's no increased risk there. So it's really important. And the downside of all this is that what percent of women who are pregnant are getting coverage with COVID vaccine? The answer is about 30% nationally, and only about 15% among people of color, women of color. So this is a big issue that people need to be aware of, the need to get vaccinated. Safety has been, thoroughly studied and assured. The effect of the COVID virus itself can be devastating. Okay, let me move on to my topic, which is the risk of mortality. I touched on that earlier, and the vaccine trial studies looked at the rate of deaths occurring in people who received placebo and those who got the actual vaccine. No difference at all, whatever, there. Among the people who, we have, a couple 100 million or so individuals now who have been immunized fully with vaccines now in the U.S. Yes, there have been people who've died. I'm told there's been something like 8,000 people out of 200 or so million. The number is about I think about 25 or so per million people. But this is a death rate that you would expect from the population who has the underlying disease profile that these folks, these high-risk individuals, based on their age, based on their underlying diseases, based on living in a long-term care facility where life expectancy is altered. All these things factor in. So the expected death rate is not differing from the observed death rate, nor is death that occurs being unexplained. They're all explained based on review of charts, autopsy data, et cetera. All that's being looked at quite thoroughly, and that issue, I think, has been taken care of. Moreover, the issue of mortality from COVID itself, again, is clear. No question about that across the board. So many different things: the effect on the heart, the effect on the lungs, abnormal clotting that may occur, et cetera, can all be reasons for much higher risk of mortality with that disease. So it's also important to remember linked to almost everything else that's being discussed, that the messenger RNA that's part of the vaccine lasts only a short period of time in the system. This doesn't persist, for days or weeks or months. It doesn't get reverse transcribed into DNA and become part of your genome. That doesn't happen. All remnants of that RNA are gone within a day or two of being immunized. So your body uses it to make the spike protein, and the spike protein then is presented to the immune system, and the antibodies are developed, et cetera. But then the mRNA goes away, just like it does in so many other forms of mRNA produced in regular activities of the body's metabolism. So no reason to worry about long-term effects. It doesn't get into your reproductive cells. It's not going to affect future children, as has already been stated. No effect on fertility that anyone can find. But if you were thinking about a way to discourage, if you wanted to actively discourage people from getting a vaccine, what would you say to counter them from getting it? You'd say it's going to affect your children. It's going to affect your likelihood of having a family in the future. It's going to cause you to die. It's going to cause you to have heart disease. All these things are, really high visceral issues for people, and that they would react to. And so even the mere suggestion of that, I think, causes people to doubt and to say, well, do I really want to get that vaccine? But of course, this information is untrue, and in part designed to dissuade people from getting the vaccine when it's entirely safe to do so.
All right. Well, I must thank all the panelists this far for their thoughtful discussion. We will now open the floor to audience questions. And as a reminder, please share your questions using the chat feature. First question.
Is that getting sick with the vaccine that I just saw popping up?
The first question that says, I've heard that the vaccine was supposed to stay in the arm area, but that it is traveling beyond the area that is a health concern. Could you give more insight on this? Dr. Roser, would you like to touch on that?
Well, yes. So the vaccines are given, they're messenger RNA vaccines. Johnson's different, but they're given to teach your body how to recognize this particular spike protein. So, in the first day or two, that is your immune system responding, and it would be, you're not sick. Although some people feel very sick, you're not sick. It is not unusual to have the arm swell and even get a fairly big hive-looking reaction. It's not an allergic reaction. That is simply the inflammatory response of your body, and it's showing that your immune system is working. And you tend, there are some people that didn't get it with the first but got it with the second, and there are some people that didn't get it with the first or second, but those that have undergone the boosters have gotten it. All it's showing is that your immune system is working. And as far as systemic effects, it is shown, other than giving you, a type of immunity and developing antibodies from COVID-19, they're very rare to have any systemic effects from it. And like Dr. McKinney said, a lot of those can be traced to something that was pre-existing. That, a lot of people say, I got the flu when they got a flu shot, and that's just the vaccine doing its job, or they already were exposed to the flu before they got the shot, and they're just coming down with it. So there can be lots of confusion with that, and people need to be educated about that.
Thank you. Our second question is, I would like to know what to say to someone about the vaccination who believes that since they got sick with COVID-19 earlier in the pandemic before the Delta variant, they are immune for life. Also, what to say to someone who got COVID-19 later after the Delta variant became prevalent. Is there any data to support the vaccine or not for these people? And Dr. Babbage, would you like to answer this question?
Sure. I think Lynn would be a better answer. However, you don't get immunization for life when you have the disease, basically. It does last, and they've proven this. All of this stuff, we've had almost 2 years now to be studying COVID. So, you know, we have a lot of data that supports the things I'm getting ready to say, but you're not immune for life. Even with the vaccination, you're not immune for life. So, but you're immune for a lot longer period of time. So if you had COVID in 2020, you need to definitely get the vaccination, because the vaccination produces a messenger in your body that helps you keep producing the antibodies a little bit longer than before, you know, so than having had the disease. The other thing is that, wait, I was going to say something else. The vaccination does help with the Delta variant. We know that they've studied now that the vaccine that we have is effective against the Delta variant, thankfully. So we don't have to have a special one. So the booster is what's going to help us continue to produce those antibodies even stronger and have them in your bloodstream for a longer period of time. You know, there's also a way for you to be tested. You know, if you're really diligent, you can be tested to see what your antibody level is, and then you'll know what it is.
And I would like to add something. So with vaccination, you're actually looking at the S protein spike. And with natural immunity, you're looking at the N protein spike. And there had been confusion with providers as far as what to look. But there's even more confusion because we really don't know a standardized yet level that affords immunity. I mean, it's not been standardized, so that is why the CDC does not recommend looking at antibodies right now, although there's studies going on. And let me just say this is a novel virus. We don't know everything. We're studying it. So to think that you could have lifelong immunity to this is so premature right now. I think that we're just trying to do the best we can to protect the American population. If you look at hepatitis B vaccines, they wane, and sometimes people have to have another vaccination. People who've had chickenpox, their immunity may wane, and they'll have to have a chickenpox booster. Same with mumps and measles. So, you know, we never know how long a vaccine is going to last. Just, you know, periodically, you know, we find out that, oh, it's waning, so then we test people. And this is true especially in people that work in healthcare, because we have to submit all these titers all the time to show how we are immune to different diseases.
I would just like to add that since the vaccine and the disease-acquired immunity don't have completely overlapping pathways, that they could be synergistic to each other. So if you have the infection, you get the vaccine, you're going to be better off, right, than anybody just getting the vaccine. So if people who would have the infection, they should be even more eager to get the vaccination.
Yeah, and let me say as well that you know, getting the vaccine, as mentioned, because of the difference in the spike protein that's produced, gives you a broader range of protection against many different variants. If you have natural immunity to one particular strain, you may have a good immunity to that particular strain for a period of time, but the ability to fight off a different strain that's somewhat you know, modified from the original one is reduced compared to what you get from the vaccine itself. You get a much more robust and broader range of protection after the vaccine. And granted, you know, boosters will be necessary, as stated, to keep the antibodies high, to keep people from getting infected in the future. But for young, healthy people who are only a few months away from getting their primary series, they're still in quite good shape for the present time, no question.
And Dr. Rattinger, can you touch more on if it is correct that you should or should not get the flu shot and COVID-19 booster within days of each other? What timing do you believe is beneficial? And if you're in submission of cancer, what do you consider to have underlying conditions?
Are you asking me?
Yes, Dr. Bedinger, I'm sorry. Yeah.
Okay, yeah, so there is, of course, there is some, again, we don't know exactly how these two vaccines may interact. And the recommended days, it's 2 weeks. I think Paul can confirm because that about when you shouldn't get a vaccine with your flu vaccine, or you get wait 2 weeks with the COVID, and if you get COVID vaccine, you wait 2 weeks to get the flu. And so, and I don't think there's any evidence that they could be synergistic with each other. With cancer treatment, it's a little tricky. So people who have immunosuppressive therapies, we do not know how they do with the vaccine. We have some data from our own study showing that people who actually are on immunosuppressive drugs don't develop a very robust antibody response, and so they might need boosters. And so certainly those have been actually marked off for people who, certain group of people who must who can get a booster if they want. So, but I think with which stage of therapy you are and what type of sort of timing or staging you can do for your vaccine, you'll have to consult with your own physician.
Let me just say there are certain live viral vaccines that are given. Recommendations for those are to either give them together or at least 4 weeks apart. The flu vaccine, the injectable form is, an inactive vaccine, as are the Johnson & Johnson and the mRNA vaccines. So it's felt to be entirely safe to give them really, and whatever timing frame is most convenient for the individual. If you can go in and get both at the same time, and that's a simple process for you, go ahead and do that. There's no reason to expect that the response to either one is going to be diminished. I wouldn't recommend that you stagger them by 2 days or 3 days, but get them together or get them a couple weeks apart or a month apart or whatever. But don't let the process interfere with your ability to get them. If you can only get them in a certain staggered form, and otherwise you wouldn't get them, it's better to get them in any timing. We haven't studied the specific response, staggering by 2 days, staggering by a week, staggering by 4 weeks, whatever. So we don't know specifically, but there's no hypothetical reason to expect that there'd be any significant diminution in response, regardless of the timing in between. So whatever works for you, if that's the way you're going to get both vaccines, go for it. And that includes getting it both at the same time is fine.
I just can't let this end without saying that masks work, and that there are many studies showing that if you wear a mask, that your rates of infection transmission is much, much lower. So there is no hesitancy about that, and no differences in data. It's just a matter of personal choice and motivation.
With that, those are excellent closing remarks and excellent words of wisdom for our audience to live on. Thanks for those who have stayed over. We've gone a little extra. This has been such a robust conversation, so we certainly appreciate those who were able to stick around. I want you to know there were so many excellent questions that came through the chat. We weren't able to fully get through all of them. We will post these questions on our event webpage, so continue to follow the conversation there. But I just want to thank everyone for joining us for today's panel. Thank you to SGA President Ugonna Okori for moderating this excellent discussion, and to our expert panelists, Dr. Aruni Bhatnagar, Dr. Sherry Babbage, Dean Paul McKinney, Dr. Lynn Roser. We thank you for sharing your expertise today and for your leadership throughout the fight against COVID. I also want to extend gratitude to Lauren Anderson, Dr. Alex Carl, and Dr. Jason Hellman for serving as a wonderful organizing team. A recording of today's event will be made available and shared on social media and the event webpage. We hope that you will share this information with your colleagues as well. Please do take a moment to provide feedback through the evaluation survey, and you can join our Why We Mask campaign by sending a selfie where you're wearing a mask and a quote of why you're masked and vaccinated to envirom@louisville.edu. Thank you again for your time and participation. Please stay in the conversation by following us on social media and visiting our webpage at louisville.edu/envirom. And there you will find information on the co-immunity study and see the dashboard on COVID wastewater monitoring. Everyone, please be well and stay safe.